This is Eric from Strong Medicine, and in this video, I'll be giving two examples of daily oral presentations for inpatient rounds given in the EAP format rather than the SOAP format. These will be the exact same cases on the same days of hospitalization as were presented in the SOAP presentation examples for anyone who would like to directly compare the two. Ms. Harris is a 76-year-old woman with hypertension and a prior MI, presented 2 days ago with acute decompensated heart failure in the setting of new-onset AFib with RVR. Overnight, the night team was paged by nursing due to new-onset confusion and modest agitation. The covering resident addressed the patient at the bedside and felt she was experiencing mild hospital-acquired delirium. Vitals and exam were unremarkable aside from her AFib's ventricular rates reaching back up into the 120s. They opted to hold off on labs because of good urine output, lack of infectious signs, and because the patient's agitation improved with redirection. Overall, Ms. Harris's acute heart failure with new EF of 30 to 40% is most likely secondary to tachycardia-induced cardiomyopathy. She is hemodynamically improved with diuresis and rate control, but now with an episode of hospital-acquired delirium overnight. Problem 1 is her heart failure. She reports less dyspnea this morning, but is not yet back to her baseline. Her pulse was 110s to 120s during her delirious episode, but otherwise had been 80s to 100s. Blood pressure 100s to 120s, over 60 to 80s. Respiratory rate is 18 to 20, and O2 sat 93 to 97% on room air. Her eyes and nose were 1.8 in and 3.2 out for a net of 1.4 liters negative. Lungs had mild basilar crackles and are improved compared to yesterday. JVP is now normal for the first time since admission. Repeat POCUS was deferred due to limited time. Mild symmetric lower extremity edema to the upper shins is unchanged. BMP is unremarkable aside from a potassium of 3.2, which was orally repleted. Overall, her volume status is gradually improving. For her heart failure plan, diagnostically, cardiology wants to hold off on additional ischemia workup for now and follow up as an outpatient to discuss whether or not to pursue testing after recovery from this admission. Therapeutically, for diuresis, we will continue furosemide 20 milligrams IV BID for today with a goal of another 1 to 2 liters negative, and tentatively plan on switching her to oral furosemide with tomorrow's AM dose. For afterload reduction, she remains on her outpatient lisinopril and amlodipine at the moment, but we anticipate transitioning her to Entresto prior to discharge. We would also like to start empagliflozin today. Problem 2 is her AFib. She reports no lightheadedness or palpitations. As mentioned, her heart rates were predominantly 80s to 100s. On exam, her rhythm is irregular, and telemetry over the past 24 hours shows consistent AFib with 5 episodes of NSVT, the longest of which was 8 beats. After tolerating an esmolol drip for the first 24 hours, she now cautiously remains on 12.5 milligrams Q6 metoprolol tartrate. Cardiology plans to proceed with a TEE and likely DC cardioversion once she's euvolemic, possibly as early as tomorrow afternoon. If cardioversion is successful, anticipate amiodarone to maintain sinus rhythm, but we'll defer to cards on that. She remains on apixaban for anticoagulation. Problem 3, her delirium. This morning she reported little memory of the events of last night. Her mental status appeared back to baseline, and she was oriented to 4 out of 4. CBC, sodium, and creatinine are all unremarkable. Given the delirium's resolution and her reassuring exam and labs, additional workup is not indicated at this time. Nursing requested an order for PRN quetiapine. I'm actually holding off on that because if the delirium recurs tonight, I would want the patient reassessed and not just sedated. Problem 4 is her hypertension. As mentioned, BP is doing well at 100s to 120s over 60s to 80s on the regimen of lisinopril, amlodipine, and metoprolol, though this regimen will likely be changed as discussed. The next problem is her CAD, continuing aspirin and atorvastatin, workup for ongoing ischemia deferred as previously mentioned. Finally, dispo. I'm hoping Ms. Harris will be able to DC back to her home in 2 to 3 days once euvolemic and in sinus rhythm, provided she is cleared by PT and OT, and her family can increase the level of in-home support. Social work and case management are currently working with them on this. Ms. White is a 38-year-old woman with no relevant chronic medical problems who presented 2 days ago with septic shock secondary to Staph aureus bacteremia. Overnight, she spiked another fever to 39.1 in the absence of any other new symptoms, prompting a repeat set of blood cultures. In summary, Ms. White's septic shock and bacteremia was initially triggered by trauma-related cellulitis. Although the shock was complicated by acute lung injury and ATN, requiring a 1-day stay in the ICU, it continues to improve without the current need for vasopressors or positive pressure ventilation. Problem 1, MRSA bacteremia and cellulitis. Subjectively, she reports this morning still feeling quite crummy, but is overall better than yesterday and is in better spirits. On her exam, her vitals included the aforementioned Tmax of 39.1 with a T current of 37.5. Her pulse is 70 to 95 and BP's 106 to 122, over 72 to 84. Cardiac exam remains unremarkable, including an absence of murmurs. There is no evidence of endocarditis on extremity exam. The warmth and tenderness of her right leg has receded to just below the knee, which she can now bend freely with improving joint pain. On labs, her white count is 12.5 from 13 yesterday. Anion gap remains normal. Admission blood cultures were updated this morning and now identified as MRSA in all 4 bottles. TTE yesterday had good views and revealed normal cardiac function with no vegetations or other valvular abnormalities. For management, we are narrowing antibiotic therapy from vanc plus cefepime to just vanc alone. We're currently planning on a 14-day course of the vanc, which will require a PIC once repeat blood cultures from today have been negative for at least 48 hours. Given that the TTE from yesterday was a high-quality study and completely normal, and the lack of any peripheral findings of endocarditis, we're holding off on a TEE, but if her repeat blood cultures are persistently positive, we'll discuss this decision with ID. Problem 2 is her pain control. Her right leg pain is improving, as mentioned, but she still does not feel well enough to walk around on it independently. She used her PRN 5 milligrams of oxycodone. She used it 3 times yesterday. I discussed with Ms. White options for treating her right leg pain, and she wants to continue the round-the-clock Tylenol and PRN oxycodone 5Q6. However, if she is still reluctant to walk on it tomorrow with PT, I will arrange additional meds and or up-titration of oxy. Problem 3 is her acute kidney injury. Eyes and nose have been even over the last 24 hours with 2.3 in and 2.4 out. Creatinine improved from 2.0 to 1.7 today. Given prior urine tests and the overall clinical situation, her AKI is secondary to ATN from septic shock. No new diagnostics or treatments are indicated. We will continue to monitor with strict eyes and nose and daily chemistry panels. Problem 4, acute lung injury. Ms. White reports that the dyspnea present on admission is now gone. Her respiratory rate has been 16 to 20, and O2 sat is 95 to 98% on room air. Lungs are now clear. Given the above, this problem appears resolved and no more treatment or diagnostics are indicated. Last is her dispo. I anticipate she'll be discharged back home pending placement of her PICC line, which will take at least another 2 days. In the meantime, we are continuing PT and OT and encouraging out of bed as much as tolerated.